Good night, everyone. Welcome back to one of our webinars. First, I would like to thank Brightbot.com for sponsoring them. I would like to remind everyone that your microphones are going to be muted throughout the presentation, but we're going to give some time at the end for your questions, which is, I think, the most important part. Also, we would like to remind you that this presentation and the ones before come from Dr. Martinez and my medical experience, but of course they do not replace a medical consultation. If you're not seeing this webinar live, or if maybe at the end you have more questions that couldn't be answered, you can go into brightbot.com and record a video question, and I will record, or Dr. Martinez or someone that knows the answer will record a video answer for you. So let's begin. So tonight we're going to be talking about intestinal cancer. Again, with me is Dr. Luz Martinez. For those of you who are new, we are both medical doctors. We are work with certain chronic conditions as cancer. So I hope you like this presentation. First, let's talk about some numbers. That's the first thing I always like to do. In 2017, over 10,000 Americans will be diagnosed with small intestinal cancer. A little more than 10% of those will die from intestinal cancer, so it's very, very important. But more important than that is that in this same year, about 10 times more Americans, so 100,000, will be diagnosed with some type of colorectal cancer, which is not a small intestine, but the large intestine. So it's 10 times more common than small intestine. And colorectal cancer is the third most common cancer for both men and women. And for men is the second cancer with the highest mortality rate. For women would be the third. But anyways, it's very, 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 very extremely important for us to know about it so we can do something about it and reduce these numbers. Amazing facts. I always put a little slide with amazing facts. There you can see the picture. I think it's amazing the length, how big the whole intestines are. Basically, the small intestine average 22 feet. But it can be longer, 25. Also, it can be shorter, but for Americans, the average is 22 feet, so it's very, very long. And the large intestine averages 5 feet. So, of course, I mean, in total, it could be 27 or 30 or more. So that's pretty amazing. How can something that large fit into the abdomen, including those people who have that like very, very flat abdomens, they still have a very large intestine. Also, a very, very amazing fact is that the intestines have their own nervous system. So it's like, in a certain ways, like they have their own brain. It functions, or it can function independently from the rest of the body, actually. Just like when you see the heart transplant, because the heart has its own, also when you see the heart transplant that it can beat outside of the body, it's very similar to the intestines. It can control itself, and it controls different things: movement, absorption, digestion, all types of things. So it's very, very amazing. Okay, so let's begin now with the subject itself. What is intestinal cancer? Of course, we already know about others, but in this case is the abnormal proliferation of the intestinal cells, and eventually causing the dysfunction of this system. Both small and large intestines have cancers, and although they might be a little different, the most common types are very, very similar. Basically, adenocarcinoma is the most common type for both large and small intestines. And basically, it develops from the lining cells of the intestine. So the most superficial parts, I mean cells. And we have to remember that since we're talking about the intestines, which is basically a tube, when we say surface, we actually mean the inner part. Uh, so that's for you to remember. Of these two intestines, the small intestine is definitely the it's very different in which if we're talking about incidence. So colorectal cancer is far more common than small intestinal cancer. And if you look at that colorectal cancer, you will find out that the distal part of the colon, so the last part of the intestines, it's actually the one that is affected the most by cancer. Here in this picture, you can see average in percentages of how much does cancer affect each part of the colon, which is the large intestine. So basically, you can see that if you add the rectum, the sigmoid, and the rectosigmoid junction, you will find pretty much more than 50% of cancers. That's why every publicity that doctors have to prevent cancer of the intestine, most of it is targeted to colorectal cancer because it's very, 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 very common. So what are the risk factors for having intestinal cancer? Age is one of the most important. That is why screening of intestinal cancer starts between 45 and 50. Now the guidelines state 50 for Americans. So that's the reason why you don't do it. That doesn't mean you're not gonna have it or you cannot have it younger. Yes, you can, but the most of the population have it under 50s or older. Men have it more than women. It's not something that is very, very different, but in a certain way, it's more men than women. Not a big difference, but for smoking, you will see that this is one of the risk factors that will share risk factors with other cancers. Smoking definitely it's very bad. Obesity, because of several reasons, hormonal reasons, and also because of GI reasons, because people with obesity have different intestinal, like bowel movements than normal, not non-obese people. So that creates a risk factor. And alcohol intake, sorry, it's definitely a risk factor also. Of course, family history is also very, very, very important. Especially the more family members you have with this, the risk definitely increases a lot more. What are the symptoms that you might have if you have intestinal cancer? Since the intestines are organs that are hidden inside of the body, and these types of cancer do not grow that rapidly, that fast, then symptoms are going to appear gradually, and you might not even notice them until definitely something is wrong. So the first thing that you might notice is that you're losing weight. Unintentional weight loss is definitely a symptom of many other cancers, but in this case of colorectal and intestinal cancer. Difficulty with your bowel movements, either because you have diarrhea or constipation, it's definitely a symptom. Of course, it is more related to colorectal cancer, and also if this is something of new onset. I mean, if this is new, you had regular bowel movements once or twice a day, and from certain point of time, recently you started having difficulties, then that's something you need to get checked. The stool might give us certain signs that we have a problem, especially the shape if you have a stool that is thin as a pencil or like stripes, it might be a sign that you have a mass uh, that's actually narrowing the colon and creating that stool that is very thin. So that happens, especially if that's something new that you need to get checked. Blood in the stool or as you wipe, it's also a sign of this. Not very, very specific to colorectal cancer or intestinal cancer because there are more common causes for this sign, hemorrhoids or fissures that we have in anal fissures. Those are more common causes, but definitely you need to get checked because there is a possibility that blood might uh, come from the stool. Now, it's important to know that most patients with cancer will have blood on their stool, but in most cases it will be microscopical. You will not be able to see it. But definitely, if you are, then you have a very good reason to go to your doctor. If you go and if you have your normal bowel movements and you still feel like you have to go even when you just went to the restroom, or you feel like there is something there that it's bothering you, pressure, or you feel like there is a mass, of course you need to go because that is a sign of especially rectal cancer. And last, but also present, I did it last because it's the sign that usually appears last is the pain. Most people will develop pain later in in time, but eventually it will appear. Some people describe it as a colic type pain, so it comes and goes. It's not necessarily there all the time. And the last one, which is vomiting, might be the actual emergency now because when cancer grows so much that it occludes the intestine, well, of course, that food and all that feces will have nowhere else to go but go back. So if you start throwing up repeatedly, especially if that vomit looks like it might be feces, that's an emergency because now that cancer would have uh, occluded the whole intestine. There are some other causes for that to happen. Of course, that's an intestinal obstruction. It can happen because you had a previous surgery or some other reasons, but definitely, no matter the reason, this symptom needs to be checked to rule out many other things, being cancer one of those.
Okay, now let's talk about the diagnosis and the treatment of those type of intestinal cancer. I will be a little bit more focused on the large one because, as Dr. Mesa mentioned before, it is most common. But now talking about the small intestinal cancer, of course, if a person is predisposed genetically to develop a small intestine adenocarcinoma or has symptoms, as Dr. Mesa mentioned before, it should be tested immediately. Here I bring three of the most common diagnosis tests. The first, and I think the most important one, is the endoscopy. We know endoscopy and we use endoscopy for gastric diseases commonly, but we can use also endoscopy for diagnosing small intestine cancer because with the endoscope we can reach the first part of the small intestine that is called the duodenum, that in fact is the most common location of cancer in the small intestine. So the good thing with endoscopy is that it has like a cut tool in which we can use it to cut or take a biopsy if we find a lesion in the duodenum. Also, we have another exam that is called quite similar, and it is called enteroscopy. It has a larger tube, and we can reach more deeper in the intestinal, small intestine, just for looking for polyps or some new lessons that we want to take off. Another diagnosis test, and we use it in conjunction with endoscopy, is the tomography, abdomen tomography. And as you can see in the picture, we can see the whole intestine, small and large one. And here, the important thing is that we can see the location, the exactly location. We can see also the size of the tumor, and it will be really important in the treatment, as we are going to see a little bit later. Another diagnosis test that we show here is the XR with barium. XR of abdomen with barium is the same, like a simple one, but before taking the X-ray, we ask the patient taking a little bit of a liquid with barium. So then, as you can see in the picture, you can see the whole intestine, the small and the large one also. Um, in the treatment, most of cases will need surgery, and it depends on the size and location of the tumor. First, maybe you will need radio or chemotherapy. So if you have a small tumor, surgery would be necessary, and that would be the only treatment you will need. But if the tumor is too big, or maybe you have metastases to other nearly organs, you will need first radiotherapy or chemotherapy for small in the size of the tumor, and after that you will need the surgery next.
Um, Here, I, I would like to add something that is kind of a novelty, not really that new, but since I already told you how big the small intestine is, it's very difficult, as Dr. Martinez was saying, to see the entire small intestine. I mean, 21, 22 feet is a lot. So now, in some places, and unfortunately, this is very expensive, so it cannot be widely used, but they are using the pills that have a camera inside, and maybe you've seen it because this is something new. But you drink the pill, and basically it will travel through the GI tract, taking pictures every number of seconds. And then at the end, you just collect it on your stool, and then they develop, or not necessarily has to collect it, because at the end, it can send wireless signals, so you can collect the images and then have a better diagnosis. Because of course, as Dr. Martinez was saying, the duodenum, which is the first part of the small intestine, is the one that's affected the most. And with an endoscopy or enteroscopy, we can see that with not many problems. But after that, it becomes very difficult. So I just want to mention that, because now I guess in the future that's going to be more like it's going to be used more as a diagnostic tool.
Yes, Dr. Mesa, that's true. Now, in the large intestine cancer, or also known as colorectal cancer, I think this is the most important part of our presentation, and we want you to know that colorectal cancer is a preventable disease. In almost 75 until 90% of cases, you can prevent it. And why? Because there are some precancerous or premalignant lesions that we call polyps, and polyps are the lesions that we're looking for when we do a colonoscopy or an endoscopy, as we were talking earlier. So it is completely preventable with colonoscopy. As we know, colonoscopy is a safety procedure. This test allows the doctor to look at the inner lining of all the large intestine, that it is a good thing. It uses normally a thin and a flexible tube that is called the colonoscope. The tube ranges for about 48 to 72 inches of long. It has a small video camera at the end of the tube, so you can see, and also it has a Q tool, so when you see a polyp, you can just take it off, and after that you can get it to the laboratory and do some tests. So we know that colonoscopy is not a funny procedure. Anyone enjoy doing a colonoscopy. So that's why there are so many excuses. For example, I'm healthy. Why do I have to get a screen? I have no history family of colorectal cancer. But the thing is that uh, almost and every people have to do the colonoscopy at a certain age. I will say you after this slide. The thing is that you will need always to do the colonoscopy. The recommendations nowadays for a normal person without symptoms, without family history, is start the first colonoscopy at age 50, or if you are an African American people, you will start at 45 age if you're a normal person. But if you have some risk factors, for example, as a single first degree relative with cancer diagnosed before 60 years, or if you have two first degree relatives with cancer, you will need to start the colonoscopy sooner at 40 age. Or if of or 10 years younger than the age at diagnosis of your relative. So if your relative was diagnosed with colorectal cancer at, I don't know, 30, you will need the first colonoscopy at 20. So it is quite important you to know that. We have another test that we call the detection test, and we need to do it in the same time with the colonoscopy. And those are the two main ones. The first is the most common and the most newer. It is called the fecal immunochemical test, and the other one is the annual hemoccult. Both tests are looking for blood in stools, as Dr. Mesa mentioned before, and they have to be done annually. So you will need a colonoscopy each 10 years, and annually you will need to do those type of detection tests annually.
Yes, this is, as Dr. Martinez was saying, the most important part. Now in America, FIT test is available and is widely used. I think is the diagnostic test that is more commonly used. Of course, doesn't replace colonoscopy. It's important to know, as Dr. Martinez was saying, one thing is to have a screening test to prevent or early detect the cancer, and it's done every 5 to 10 years now. Actually, we do it every 5 for people age 50 and older. But FIT tests need to be done yearly at least, because they will let us detect some blood and then maybe detect that cancer if it appears in that 5 year period. Of course, it has certain limitations, because if you are bleeding for any other reason, it won't be the best test to do to rule out cancer. So in that case, if you have hemorrhoids or any other cause for bleeding, you might want to consult with your GI doctor or your PCP just to discuss other alternatives, being, of course, the colonoscopy one of those.
Okay. Now, the treatment in this type of cancer is quite similar of the small intestine. The first choice will be the surgery, and of course, and also it depends on the size of the tumor. If you have a not too big polyp, as you can see in the picture, you can just take it off, and that will be all the treatment. Of course, you will need to a follow up with colonoscopy more sooner than 5 years. We have another type of surgery, and it's just removing the part with the tumor, and after that we can join it in the same surgery, the healthy portions. But also, as in the small intestine cancer, if the size of the tumor is quite big, or you have metastasis, you will need first some sessions of radiotherapy and chemotherapy, and after that surgery will be done.
Yeah, so definitely what it's been repetitive in our slides is that polyps are very important, because polyps are the primary lesion that will lead to cancer. So of course, whenever GI specialist sees on the colonoscopy or endoscopy or any test, if he sees polyps, he will try to remove them in that exam, because that's how cancer develops. There are certain conditions that predispose, certain patients to have these polyps, being familial polyposis, one of the most common conditions. So for those people, the screening should be done probably yearly or even more than that. There are some other conditions that might increase the risk for this cancer that can also be detected, like Crohn's disease or irritable bowel syndrome. Those are also conditions that can predispose to cancer. And for all of them, colonoscopy, again, it's a very useful tool just to see if something's wrong.
It's also important you to know that there are many types of polyps, and not all of the polyps are malignant. So that's why we take off all the polyps that we can find, and after that we take them to the laboratory. And depending on the response of laboratory, we will need a sooner colonoscopy, maybe 6 months after the last one, or just it was a benign one, and you will need the other one 5 years after the last one. So it will depend on the laboratory.
Okay, well, thank you for listening to our presentation. I hope you liked it. Now it's the time for your questions, and they are always very good. So go ahead, please.
Dr. Mesa, why
Yes.
would you have the chemotherapy and the radiotherapy before the surgery? Why not the other way around?
Because sometimes the tumor can cause some other complications, either because it is too big or because blood vessels are attached to the tumor, or because the tumor itself might be attached to some other organ. So if you do chemotherapy and radiotherapy first, you might actually decrease the size of the tumor, you might decrease the blood vessels that are feeding that tumor, and then make surgery easier. And of course, in some cancers that are already metastasized or that are so big, it will help us to gain a little time. So we don't necessarily wait for surgery, because not always this will be an emergency surgery. Anyways, you need to go through certain steps before getting the surgery, getting a pre-op clearance. So in some cases, we choose to do chemo and radiotherapy just to start fighting the cancer as soon as possible before we actually go to surgery. So those are like the main reasons.
Thank you.
You're welcome.
Doctors, if a polyp is found or polyps are found, there's that 5-year window where you would have to go back again for another colonoscopy. If there's nothing, then there's that 10-year. Who came up with those numbers?
Okay. First of all, actually, everyone should now, at least based on American guidelines, actually it's every 5 years. If it's normal, you should get it every 5 years. There are some other countries that might extend it to 10 years. That depends on your age. But to answer the question of who came up with these guidelines, well, there are several medical organizations that work together to combine the results of different studies. Now being American Cancer Society, one of the biggest organizations that is releasing these guidelines, telling us that colonoscopy should be done after 50 years of age and every 5 years. Because before, when the studies were not out, when the results were not out there, we were just guiding by instinct and our experience. So we were actually, instead of doing it less, we were overdoing this colonoscopies, and we were starting too young, so it was unnecessary. We have to remember that colonoscopy, even when it's a relatively safe procedure, it can, in certain cases, lead to very bad complications. So we try to expose our patients less by actually doing everything based on evidence. So American Cancer Society is #1 that we use, and actually is the one that tells us to do it every 5 years. But there are many other. I don't know if you know other societies, Dr. Martinez.
Oh yes, Lorna. It says that it takes almost 5 to 10 years a polyp to begin starting with malignancy. So that's why the evidence of, for example, American College of Gastroenterology, it take the 5 years as a number, as an statistical number. But if a polyp is found and it's a malignant one, so you will need for American College, you will need another colonoscopy 6 months after the one you find the polyp that is malignant. But if the polyp will need another in 5 years. That is the reasons I know, the numbers I know. Yes.
Okay, thank you. I
You're welcome.
have another question. You had said about obesity is another factor in colorectal
Yes,
cancer and intestinal cancer. Why
it
is
is.
that again? I didn't quite get that.
There are many reasons why. I mentioned the reason I mentioned is because it might change your bowel movements. Obesity actually changes the whole pressure in the abdominal, the abdomen actually. But that is just one of the many reasons. Obesity also changes the hormonal production because itself actually the intestinal tract or is affected by hormones. It is also because people with diabetes or might have also a higher risk of intestinal cancer, and obesity and diabetes are also very related. It's not that there is a very specific and unique cause, but there are many reasons surrounding obesity: hormonal changes, pressure changes, um, other related conditions like diabetes or irritable bowel syndrome, which is also related to obesity. So basically, that would be the answer.
Thank you.
You're welcome.
Doctors, I got a question, and you have kind of answered it somewhat in the, in the process here about polyps. I gather that not all polyps become cancerous, but my question still is, are polyps basically bad that they should be removed? I mean, regardless. I mean, what's a polyp anyway?
Okay. Well, I think this will be an answer that we will both talk about, Dr. Martinez and me, but I'm going to start with the first question, well, not the first question, but the last actually, which is, what is a polyp? So a polyp is a part of any tissue, because polyps are not only for intestine, but in this case, a polyp would be a little mass that is formed of the same cells of the lining of the intestine. And it has a main characteristic, which is that it has what we call a podocyte or a pedicle, which is like a little foot. So it is basically something shaped as a tear, which has a big like chunk of tissue and a very narrow neck. So it's something that hangs from the intestine itself, but it is made of the same cells. For the second question, not every polyp is cancer, but it might potentially become cancer later on, because these polyps are always exposed to the movement of the bowels. So they are in a certain way being twisted and being scraped by the feces when it passes through and by the movement of the bowel. So it's getting injuries and healing, injuries and healing. And if you study other types of cancer, you will see that this is something that they have in common: injury, healing, injury and healing, inflammation and healing eventually will trigger uncontrolled growth.
So yes, we used to remove all type of polyps just because at macroscopically or just with the camera, we can't know which type of polyp we are talking about. So we need to take off all the polyps to get to the laboratory and to know what type of polyp it is. The adenomatous polyps are the most common malignant ones. So that's the reason why we take off all the polyps that we can find in the colonoscopy.
Okay. So just having polyps, having them find polyps doesn't really predispose you to being having cancer later on then.
No, it does, because like I'm telling you, having them will make you have those injuries and healing just for you to have it. Is that for us it's difficult to just know which ones are gonna actually become cancer. So since we are already looking and it's relatively easy to remove them, we remove all of them to know which one has the cancer or not. But yes, having them, it's a risk factor, having polyps.
But
Polyps, it's very common. A lot of people have them. So the more you have, actually, the higher the risk is.
okay, yeah, that was going to be my follow-up question. And that some people more or less predisposed to having polyps, or is it just a general?
Yeah.
Yes.
Yeah, that's right.
For example, people with genetic or family history of colorectal cancer. Also, as Dr. Mesa mentioned before, there is a disease, the non-polyposis disease. Those people are in an increased risk of having colorectal cancer. Yes.
Okay, thank you.
Okay.
Dr. Mesa,
Yes.
what about diet? Is there any studies or anything that shows that a certain type of diet would make you more be more predisposed to polyps or even the colorectal cancer?
Yes, there are, definitely. Having a diet that is rich or poor actually in fiber is definitely related, and obviously the opposite. Having a diet that is rich in fiber gets a kind of protection against colorectal cancer, because like we were mentioning before, part of the whole reason why you get it is because you have either a lot of pressure in the small bowel, or you have polyps that become injured and then they heal back again, and this happens back and forth. So if you have if your stool is soft and you don't have to make or create a lot of pressure, then the risk of you to actually causing injuries to your bowels will be lower. So definitely, yes, rich fiber in your diet will definitely protect you against it. So I would be fruits. I mean, vegetables. They're good fiber because contrary to what people think, most parts of the vegetables cannot be absorbed by the intestines. So they basically pass through exactly the same as you eat them. So they're very good fiber. And also, the skin of the fruits are also a very, very good source for this type of fiber. So I would definitely recommend people to add those things in their diets to prevent colorectal cancer.
Also, there are another factors that you can do for as a protective benefit against the colon cancer. Low fat diet will help you, of course. Increase the amount of liquids every day. Of course, having regular exercise. In menopausal women, estrogens have a modest protective benefit against colon cancer, of course.
Thank you.
Okay.
The chemotherapy that's used for intestinal cancers, is it any different from, say, the chemotherapy used for like a breast cancer? Because I know it's different types of cells, but does the chemotherapy change then?
It might change. We have to remember that breast cancer, or at least some types of breast cancer, are very receptive to estrogen and to some hormones that mimic estrogen. Um, Colorectal cancer, although it is in theory a cancer that affects um, cells that are also considered part of the endocrine system, or well, a gland basically, not necessarily endocrine. But those glands are affected by other hormones, but not estrogens. So when we do chemotherapy for breast cancers, in some cases we choose special medication that will target estrogen receptors, so we block that interaction. In the case of intestinal cancer, well, of course, we will not use those type of medications. And of course, there's a very wide range of chemotherapy agents that they are very different. In this case, since the lining of the intestine is it's mucosa, basically it heals very fast, and cells, abnormal cells might grow very fast. So we need an agent that works as fast as these cells are reproducing. So yes, the answer is yes. We use some different chemotherapy agents for those two types of cancer.
And normally also, because of the reason of Dr. Mesa says, of the rapid healing of this type of cells, the chemotherapy for intestinal cancers normally lasts a little bit long than for breast cancer. So yes, it will change the name of the pharmacologist, and the duration. It will depend of the stage and the size of the tumor.
Okay.
I
You
have
sure?
I have some questions if you don't mind.
Okay.
First question is what is the difference between a diagnosis and a screening?
Okay. Very good question. Screening is a test that was developed with the only purpose of detecting something in a population. So basically, we take studies and statistics, and we target one test which is good to detect as many people as we can. We also choose a test that might be affordable for people, and that will exclude the least amount of people, because that doesn't necessarily means it will be the best test for the diagnosis, but definitely for that type of population will be the test that will cover more and that will detect the most. And diagnosis, in the other hand, is a test that is specifically done for to actually confirm that a certain condition is present there. So in that type of test, we're not taking into account if it's affordable or not, if it's risky or not, because the main reason we do it is because we want to definitely confirm that we have it. So first, we use screening tests. In this case, for example, after years of studies, we discovered that cancer affects people between 50 and 65 or 50 and 70. And that the first lesion will be polyps. So we determined that a screening test will be something to look for polyps every 5 years. So that's how we came up with the colonoscopy. But there's, for example, we could use CT, which might be a little cheaper, but will not necessarily detect as many cases as the colonoscopy. So screening tests are tests that we can apply to a big population, which are not very expensive, and that will lead to the highest amount of early diagnosis. Basically, that's the question, the answer, sorry.
And also, usually, screening tests are made for healthy people, as Dr. Mesa says, just for finding some polyps, for in this case, in colonoscopy. And diagnosis test we use is when we have a suspicion of a certain disease, just to get a certain diagnosis. So it is not for healthy people.
So basically, the screening test is like when you're in a gold mine and you see the people in the river trying to find out if there's gold in the water. So as soon as they find something, then they will start digging up for gold. That would be the screening, and actually digging for gold will be the diagnostic test.
I understand. Specifically for colon cancer, what are the different types of screenings available?
We have both. We have two main. The first and the most important is the colonoscopy, and we have another one that is much easier to do, that is called the sigmoidoscopy. And is the difference is the large of the tooth and the quantity of large bowel we can reach with the camera. With sigmoidoscopy, you just reach to the sigmoid part, that is like the third part of the large bowel. And with the colonoscopy, we can reach all the colon, and that's the difference, that the two main kinds of tests we have.
That would be invasive tests, which are a little risky, but they're the best because you can actually look. And the other type of screening that we have would be the fecal immunochemistry test, which is the FIT test, which detects very microscopical amounts of blood in the stool. So that's something we use yearly after age 50, and colonoscopy every 5 years. So those are the two main tests, screening tests, sorry.
I know what a polyp is, but what causes a polyp to form?
It's a very difficult question because we're not really sure what's the cause. We know that there might be certain genetical predisposition, because we know that people with certain gene mutations will develop more polyps than others. But in a certain way, we have to know that polyps are like benign tumors. So they're between a benign growth and a malignant one. I would say that 80% of characteristics are similar. So basically, there's something in the DNA or in the genome that basically causes abnormal growing of cells. But then in the ones that have cancer, the other 25% or 20% of the genetic material simply triggers the cancer. But they're very, very similar, malignant and benign. I don't know what you have to say about that, Dr. Martinez.
Yes, we have, I think, the genetic factors, as you were mentioned, and mechanical factors, I'll think, to answer your question. Increasing of the pressure, as Dr. Mesa was telling before, because of a low fiber diet or obesity, will be a risk factor for having polyps, just because increasing the pressure will make the intestine wall to blow up and just make the polyp. So I think it will be the reason: genetic factors and mechanic factors.
Thanks. And here's my last question. You know, the guess the intestine. I think it's the intestine that's long like this. Is it less likely that the cancer can metastasize from a part that's further away from the rest of the body, like for instance the anus? Is it less likely for anal cancer to metastasize Or is this a really bad question?
No, I don't believe in bad questions. Every question is good, actually. Well, we have to understand that for cancer to metastasize, we have different ways in which different cancers do it. Some cancers use lymphatic um, lymphatic way to do it.
Vessels.
We have to remember that besides veins and arteries, we also have a network of tubes that we call the lymphatic tubes, which are part of the defense system of the body. Some cancers might actually, some of the cells or, yeah, might travel through that system. Some others, in the other hand, will choose the blood directly. Those cancers that choose blood, they can metastasize to to places that are far away from that, because lymphatic tissue tends to hold the tumors very locally, and rectal cancer might be one of those. But intestinal colorectal cancer might choose other type of metastasis and might actually go a little bit farther. So yeah, maybe rectal will stay very local, but intestinal might actually metastasize to places that are far away.
Okay, thanks.
You're welcome. Well, thank you everyone for your attention. I hope you liked it. Again, your questions were very, very good. We liked them a lot. See you in our next webinar. And again, thank you brightblood.com for sponsoring them. Have a good night.
Good night to
Good
everyone.
night, Dr. Mesa. Good night, Dr. Martinez.